I would be covering the history, indications, physiology, and dosing part. And Dr. Vikrant would cover the contraindications, effects, and recent advances. So a little bit about the history. It was this terminology was derived from a Greek word, which means to take away by force. So it refers to the general technique of extracorporeal removal of a blood constituent. So in 1914, this was initially suggested as per treatment for hyperviscosity by Dr. John Abel from Johns Hopkins Medical Institute. Later on in 1950s, it was first employed to control hyperviscosity in multiple myeloma case. And then in 1960s, it was accepted as a standard therapy. Gradually, in 70s, it evolved as a treatment modality for many neurological diseases. And eventually, with modern apheresis machines, the therapeutic plasma exchange became feasible. And in 1986, it was endorsed as a therapy for reduction in symptoms in myasthenia gravis, GBS, and TTP. So moving ahead, what are the indications that was suggested by American Society for Apheresis? They have divided into four categories, in which category one, in which the apheresis is accepted as a first line of therapy. That was either as a primary treatment standalone or in conjunction with other modes of treatment. That was like in GBS, TTP, myasthenia gravis, or Goodpasture syndrome. The second category where this apheresis was accepted as a second line therapy, either as a standalone treatment or again in conjunction with other modes of treatment. That was in cryoglobulinemia, multiple sclerosis, whether in an acute attack or a relapse case, and ABO transplant incompatibility. Third category, in which optimum role of apheresis is not established. So the decision making was individualized, like in HIT and thrombosis and IgA nephropathy. And category four, where there's published evidence which suggests that apheresis is ineffective or harmful, like in cases of rheumatoid arthritis, schizophrenia. There's a long list of these indications, but in short, or commonly, what do you say, common disorders that we can see. In short, this is the categorization. A bit about physiology, as to what kind of substance or what is the ideal characteristic that is to be removed by this therapeutic plasma exchange. It depends that it should have a large molecular weight. It should be distributed in the intravascular space. Should have slow rate of formation, should have a prolonged half-life, and the turnover rate should be low. So just an overview, what does it comprise of? So this apheresis comprises of therapeutic plasma exchange, photopheresis, and cytopheresis. So plasma exchange would be by centrifugal technique, double filtration technique, or the plasma pheresis, this plasma filtration technique. Whereas cytopheresis would involve erythrocytopheresis, that is the RBC removal, platelet, or WBC. A bit elaborative table on this is the various kind of procedures and what are the molecules that are targeted. So the adsorptive cytopheresis, that would clear the monocytes and granulocytes. Then for the autoantibodies, immunocomplexes, and lipoproteins, we have the double filtration plasmapheresis. Then for immunoglobulins, we have immunoadsorption. For what do you say, high molecular weight plasma components, we'll have the rheopheresis. And for various different cells like the RBC, WBC, and platelets, we have this erythrocytopheresis, leukocytopheresis, and thrombocytopheresis. So what are the two different techniques that is involved in this? That is by centrifugation method. where they don't use any filter membrane. It is by centrifugal force, and the other is membrane filtration, as the name suggests that there's a membrane involvement for this technique. So membrane filtration will only separate the plasma, whereas centrifugation method, it will fractionate any of the blood components, as the erythrocytes, platelets, and plasma. So centrifugation, like I told, it doesn't require a blood membrane interface. There is this centrifugal force in which there's this spinning at around 2000 to 2500 revolutions per minute, and it separates the blood components, that's the anticoagulated blood, as per the density. So the innermost layer would be the plasma, then above that would be the buffy coat that would contain the WBC and platelets, and the outermost layer would be the RBCs. So centrifugation can pack the RBCs to a hematocrit level of more than 80%. So for this, we can use a peripheral vein access because the lower blood flow rates are sufficient. And with this lower blood flow rate, we can remove large plasma volumes. So shorter session time is needed for the same. So this is a diagram where you can see here is the patient's axis. So it comes out from the patient where they add on anticoagulation, depends, citrate or heparin, where it is added over here. Then it goes through a centrifugal pump where here the plasma is removed. Once the plasma is removed, then we add on the replacement fluid that can be either plasma or albumin. And then it is added on. Externally, we give calcium supplementation because hypocalcemia is a common adverse effect with this. So we have to externally supplement calcium and then it is infused in the patient. Now this is centrifugation method, and whereas the membrane separation method is similar, but instead of the centrifugal force, the blood is it goes through the blood pump, anticoagulated blood, and then it goes through this plasma separation filter, which through convection it is transported, and then the replacement fluid is infused after the filtration along with the addition of calcium, then it goes to the patient. So this separation efficiency in membrane filtration, it depends on the membrane properties, that is pore size, surface area, and sieving coefficients, which depends on the protein binding, molecule size, and the charge. So serum protein adsorption to the membrane will lead to filter clogging and decrease the separation. Higher ultrafiltration rates will lead to high filtration fractions and probably can cause RBC damage. Eventually, the clotting of the filter may occur. So therefore, membrane filtration is limited to a filtration fraction of around 30 to 35% of the plasma. So eventually it requires high blood flow rates and longer treatment sessions. So that is why central venous access would be necessary for this modality. Now, factors which can influence the plasma filtration, that is the transmembrane pressure and the axis, blood flow rate, which has to be minimum 100 ml per minute or maximum of 250 ml per minute. And third thing is patient's hematocrit. So to decrease the transmembrane access pressure and the filtration fraction, we have to decrease the replacement rate or the patient's plasma loss flow rate, or increase the blood flow rate. So just a table to demonstrate what's the difference between both the methods. So like I told, centrifugation, the mechanism is by centrifugal force, and membrane filtration is through convection. The blood flow rates, if you see in the centrifugal, it is quite low, 10 to 150 ml per minute. But if you see the plasma extraction, that is 80% in this method. The same way, if you see in membrane filtration, the blood flow is around 150 to 200 ml per minute, whereas the plasma extraction is just 30%. So the molecular weight in both the cases is the cutoff is more than 15,000 Daltons. The volume of distribution is low. Protein binding would be more than 80%. Now, there is also a difference in the anticoagulation that would be used. For centrifugation, they would use citrate. We'll see in the next slides why citrate, why heparin, why it is preferred. So prior to the dosing or prior to the prescription, what we need to take into account is the vascular access, what kind of anticoagulation we need to use, and what kind of replacement.
Reshma, interrupting on this, that any comparative advantage, disadvantage, or any context which one should be sort of selected? Anything that you
About
want
the
to
citrate
highlight?
and heparin, sir?
No, about the three different processes, that membrane separation, centrifugation, or dialysis. Which one should be used at what context?
So still further, I
You
I
have?
think no, I just have the access and type of replacement fluids. No,
No.
Sir, I will cover
that's
that in my talk.
Okay, Vikrant, you are covering, right?
Yeah.
Okay, fair enough. Sorry, you carry on, please.
Like
One
we
question,
discussed.
Reshma, I've got one question.
Yes, sir.
How long does it take for the centrifugation versus our plasma exchange by our dialysis machine? How long is centrifugation? I have not used centrifugation at all in our patient. How long does it take? Centrifugation.
Shorter time with the
How
centrifugation.
long? Our hemodialysis machine usually it takes hour and a half. How does it take longer time? I thought it took longer time. I thought, if you make a blood flow of 10, it should take a longer time. I don't know. I'm not familiar with it. So that I think we should check that thing out. Correct or not? Arvind, any comment?
You're absolutely correct.
Let's wait. Let's see. Find out. I think we can find out and let's see. Okay. Okay. Sure.
Yes, sir.
Thanks.
Yes, sir. How do we determine the ideal vascular access? That would depend on the procedure, like what kind of centrifugation or membrane filtration technique, what is the urgency, how much volume needs to be exchanged, and how frequent you need to do these cycles. That's the procedure related factors. Patient related factors would be the underlying disease, mentation, and the vascular anatomy. And the third thing would be which kind of machines does the institution have. So that depends on the institutional capabilities also. So as per that, we determine the vascular access. So in adults, for low blood flow rates, 16 to 19 gauge needles are used. So that would give a flow of around 80 to 100 ml per minute. Whereas central venous dialysis catheters, 11.5 French catheters should provide a consistent and reliable blood flow rates, either placed in jugular or femoral veins. Single lumen ports can be used for access, and replacement fluid, I mean, when we return the blood, that can be done via the peripheral access, or when we have dual lumen ports, that can be used for the same. Ports may be usually associated with low infection rates and provide greater patient comfort. And the fourth would be through arteriovenous fistula or grafts. This would be a very good choice for patients who would undergo repetitive exchange, because these accesses, they provide fast blood flow, low risk of infection, and long-term patency is good. But it is used less because it depends on when this fistula is created, how much time it takes for maturation. So not much of patients, they have documented that they use the arteriovenous fistulas or grafts. So we're talking about the anticoagulation to maintain the patency of the circuit, that's citrate or heparin. So it depends on the method of apheresis. Also depends on what are the comorbidities of the patient, whether there's underlying liver cirrhosis, kidney failure, or thrombocytopenia. Need for systemic anticoagulation for other indications, as in when a patient is on ECMO and we plan for this apheresis. So the kind of anticoagulation would depend on that also. So citrate would be preferred because of its regional effect and short half-life, and the safety profile is good. It is infused in the circuit before the pump. Means like we saw in that diagram, once it comes out of the patient through the access point, then it is anticoagulated and then it goes to the pump. What citrate does is that it chelates the ionized calcium to prevent the activation of the coagulation cascade. So in centrifugation, the risk of citrate toxicity is low because 80% is removed with the discarded plasma. So it requires higher blood flow rates and clears only 20 to 30% of the citrate. This increases the risk for citrate toxicity, particularly in patients with liver or kidney disease. So there, heparin would be preferred. To avoid systemic hypocalcemia, calcium must be replaced. And most commonly used citrate solutions would be citrate dextrose formula, which is a hypertonic solution. That is ACDA, and other solution is ACDB, which is isotonic to plasma. Now, heparin has a short half-life, but that would be around 23 minutes to almost 2.5 hours, and is almost entirely clear during the plasma exchange. So during the start of the treatment, it is administered, followed by, if needed, we can give a continuous infusion. It is preferred in membrane filtration plasma exchange. Clotting risk is low enough. So without anticoagulation, also with the modern equipments. So that's how we decide whether it is anticoagulation, what is the dosing, what method or which drug is preferred. So patients who are already receiving anticoagulation, so for patients receiving a heparin drip and undergoing centrifugation plasma exchange, one might approach to discontinue the drip 1 hour before the plasma exchange with citrate infusion. Patients who are currently receiving warfarin, low molecular weight heparin, or NOACs may be challenging because of longer drug half-life, less availability of reversal agents, and reduced ability to easily monitor the bleeding risk. The plasma exchange with albumin replacement is safe to perform in individuals receiving warfarin, although albumin replacement increases the anticoagulant effect through removal of the clotting factors. Now, many institutions, the plasma exchange is performed with citrate or heparin in patients receiving pre-existing anticoagulation. And probably in pediatric patients, many centers use a combination of heparin and citrate dextrose A solution to minimize the amount of citrate, although the ratio of whole blood to anticoagulant would be around 26:1 that may be used. So what kind of replacement fluid would be done? What's the choice? That would depend on, again, the indication for apheresis, infection, bleeding risk. So replacement fluid, it can consist of colloids, crystalloids, or a combination of the two. So crystalloids are typically only used for hyperviscosity syndrome. Human albumin solution is used most frequently for its oncotic properties. Bit about albumin, 5% albumin solutions which are available. This approximately has around 145 millimoles of sodium and less than 2 millimoles per liter of potassium. So plasma exchange followed by albumin replacement will result in a 50 to 60% reduction in the pro and anticoagulant factors. But the rebound is biphasic with an initial increase of the levels 4 hours after apheresis and almost complete recovery by 48 hours. Coagulation testing should not be performed for 8 to 12 hours after albumin replacement. But with this albumin, cost is a limitation. So some use this combination of albumin saline solution, which can be like a minimum ratio of around 70 is to 30. So these diluted replacement fluids, they carry a higher risk for hypotension, and that's why the use is limited to only hyperviscosity syndromes. And because the albumin is heat activated, it has a lower risk than plasma for the hypersensitivity reactions, TRALI, and transmission of infection. Plasma is primarily used to replenish.
Just one question. So,
Yes, sir.
Reshma, sorry. So you mean you are diluting further the 5% albumin itself?
It was mentioned about 5% albumin only, sir, यहाँ पे.
Gandhi sir, any comment on this? Because I'm little
See,
intrigued on this.
we use 20% albumin, almost 3 pints, and then we use colloid like Himaxil or Voluban, rather than going continuous albumin only, because albumin becomes very expensive proposition. Correct or not?
Sir, Rahul here.
Pandit sir. Pandit sir.
Sir, Rahul here. There is now, sir, overwhelming evidence about plasma expanders, especially starches, that did actually worsens outcome in critically ill patients. So almost for last 6 years, we have exclusively stopped using plasma expanders, sir. So
Yep.
albumin is good. In between, if you want, we can use plasma as such, but I understand plasma carries its own risk of TRALI as well as other things. But albumin transfusion is good, and crystalloids, the rest of it we can substitute some.
What will be ratio of albumin versus crystalloid? How much do you give it, Dr. Pandit?
Sir, 50-50 can be given, up to 50-50 can be easily given, sir.
50 can be given. Okay. If you give 2.5 liters, we remove it. 1.25 by albumin and
1.25.
1.25 by
Yes, sir.
crystalloid.
Crystalloid, sir.
Okay.
Yeah.
Okay. Fine.
But
fine.
I understand your point, sir. Albumin becomes expensive. But sir, abhi ye jo trials which have come out with starch, the success trial, the chest trial, all those trials have shown overwhelming evidence of increasing renal failure. And ye jo 6% hydroxyethyl starch ke jo trials the plasma pheresis ke, these are all German trials. In fact, the trials have been busted, and there is now the author have withdrawn the manuscripts because they were fudge data pura. So the 6% hydroxyethyl starch pura abhi, matlab even in plasma pheresis, very little evidence remains in the literature to actually use it.
Okay. Because see, our patient not critically ill. Many times our patient we use it
Sir,
for neurological reason.
non-critically ill patients, absolutely we should use it because there is no
Okay,
evidence
fine.
for that. Only
Okay, great.
critically ill patients who are sick, who are on organ support, who may be on dialysis because of a clinical problem, not
Okay.
dialysis because he's on end stage renal disease. वो तो
Okay.
उसको आप यूज करोगे तो कुछ प्रॉब्लम नहीं है सर.
Okay.
Major problem is with kidney. So if the kidney is salvageable, then we should avoid using it. If the kidney
Okay.
is not salvageable, then it doesn't matter whether you use hydroxyethyl starch or whatever. It is okay.
Okay.
Yeah.
Okay. Sure. Thank you.
Thank you, Sam. Thank you. So, Arindam, what was the question? Original question about 5% albumin? क्या पूछ रहे थे आप?
हाँ सर 5% यहाँ पे यो जो बोल रहा है जो 80-20 या 70-30 dilution, but Reshma started with the 5% albumin. So I was wondering that 5%, then again using it 70-30 dilution, whether it would suffice, because most of the time practically we have seen 20% to be used.
Yes. So most of the practice is 20%. I think volume, if you consider volume, then you will have to basically use 20% albumin. The volume which has been given is talked about in 5% albumin ratio only. So अगर आपको 1.25 liters albumin देने का है तो 20% नहीं है, वो 5% albumin है. Most of the data actually comes with 4% albumin, not even with 5% albumin, because abroad जो मिलता है वो maximum 4% albumin मिलता है, 5% नहीं मिलता है, नहीं तो 20% concentrate मिलता है.
ठीक है,
Sir.
Reshma, you carry on.
Sir, this data already suggested that 5% albumin is to be used for dilution. That is
Correct.
5 gram per DL, sir. And it is
Correct.
to be added, not 20% of albumin, since it's more concentrated. So the 5% albumin of 5 gram per DL is to be diluted with 40% to 20 to 40% of crystalloid.
Yes, agreed. Yes, that's what I'm trying to say. That when the large volume is there, it is 5% albumin only, which we are talking about. So 1.2, जैसा मैं गांधी सर से बात कर रहा था कि 50-50 तक दे सकते हो आप volume to crystalloid. It is 5% albumin to the crystalloid ratio. Absolutely correct, Himraj. Absolutely correct. Spot on. Yes.
Reshma, carry on.
So regarding plasma, it is primarily used to replenish the aromatase 13 in TTP and clotting factors in patients with bleeding. It is typically either fresh frozen plasma or a 24-hour frozen plasma. So 3 or more sessions of daily plasma exchange may require with around 2 to 4 units, which means 2 to 4 bags of FFPs, which would account to around 500 to almost a liter of quantity of FFPs to reduce the bleeding risk. Now this FFPs contains around 7 millimoles of citrate per unit. So that would increase the risk for citrate toxicity with large volume infusions, because the unit size would be in and around 200 to 300 ml. So a single plasma volume exchange of around 3 liters will require multiple units, which is obtained from many donors. So the selection criteria would be when the fibrinogen level is around less than 125, coagulation factors are abnormal, or there is thrombocytopenia. So to prevent allergic reactions.
Just hold on, Reshma.
Yes, sir.
Gandhi sir, I have a question, sir. Sir, TTP में जब ये आप करते हैं, do you use 100% plasma nowadays, sir, or are
Yeah.
you using some albumin as well in that, sir?
Ideally, you should use the 100% plasma if possible. Ideally, you should
Yeah.
use that thing. That's the
Yes, sir.
recommended right thing.
Agreed, sir. So on the same corollary, we use it for a non-renal indication nowadays in liver failure. So especially drug-induced liver toxicity or drug-induced liver failure, there is overwhelming literature which is coming now. Though there is no big randomized control trial, but number of small center studies which talk about 6 liter, 7 liter plasma exchange in these patients to optimize them for liver transplant. There also they are talking about maximum use of plasma only. Any experience in that, sir? I have done 2-3, but I don't know whether that much of high volume of transfusion we should be actually giving for somebody.
See, recently we had one patient. I don't know you knew about it. That patient of liver transplant. We did
Yes.
plasma exchange in the thing. And
Correct.
the reason I talked to the liver transplant team, because I told you regularly what we use the albumin and the crystalloid. And this one they said
Yeah.
no, they would use only FFP only, and we use
Only
only
FFP.
FFP during the plasma exchange with the
Correct.
HUS following with the tacrolimus toxicity.
Yes.
Okay.
So there also we are using only plasma nowadays. So
Correct.
these are the two indications where we would use plasma, which is liver toxic, drug-induced liver failure for optimization or for tacrolimus toxicity, and second would be TTP.
Correct. Okay, absolutely agree.
Thank you, sir. Thank you.
Sir, one more thing, sir. In TTP, rather increasing the volume of plasma, there is some data suggesting that the twice daily plasma exchange is more effective than increasing the volume of plasma, sir, in a single session.
Oh, really?
So,
I didn't know about
Yes,
it.
sir.
So number of regimes have come, Himraj. It all depends on how bad your hemolysis is. In early stages of hemolysis, you can do 12-hourly plasmapheresis as well with volume with plasma exchange. But there is also a daily regime. There is also a 3 days, then a break, and then 2 days regime. There is also alternate day regime. I think all of them actually point out towards a reasonable outcome. But I agree that if the hemolysis is very bad, we should do a daily regime.
Okay, sir.
I think Reshma, you can continue now.
Yes, sir. So to prevent allergic reactions with this plasma exchange, patients are often pre-treated with diphenhydramine pre-procedure just to avoid these reactions. Risk associated with donor plasma is transfusion reactions and citrate toxicity. There's high rate of infection transmission in low and middle income countries, whereas the risk is extremely low in high income countries. I have two examples regarding the dosing prescription. There's a case of 42-year-old lady who is weighing around 50 kgs. She presents with fatigue and headache since 2 weeks. She presents to the emergency department where she has tachycardia of 115 beats per minute, BP is around 120/65, and she has a petechial rash, and she appears to have a toxic look. Labs are suggestive of hematocrit of around 18%, platelet count of around 12,000, creatinine level of around 1.3, LDH of around 2100 units per ml, haptoglobin of less than 6. Peripheral blood smear shows 15% schistocytes. So you decide to initiate plasma exchange for treatment of likely TTP. So what's the estimated plasma volume to be exchanged? Is it 2.7, 3.7, 4.7 liters or 5.7? How do we calculate this? So I'll just enumerate the three questions and then we go on to how do we prescribe this dose. So also, which one of the following is the most appropriate initial prescription? That is 2 plasma volumes exchanged every other day, 2 plasma volumes exchanged daily, 1 plasma volume exchanged every other day, or 1 plasma volume exchanged daily. Which is the most appropriate prescription? And what kind of replacement fluid would be appropriate in this case? That's FFP, albumin, combination of albumin and FFP, or a normal saline solution. So the average blood volume in adults is around 6.5% of the body weight. That's around 5 liters, of which 60% is plasma. So the estimated plasma volume can be calculated like 0.065 into weight in kgs multiplied by 1 minus hematocrit in percentage. So 1 plasma volume exchange, it removes around 65 to 70% of the targeted substance from the intravascular compartment, right? So equilibration between the blood body fluid compartments, it determines the net clearance of the substance. So that is represented by this equation. As the ratio between the volume exchanged and the estimated plasma volume, this increases, there is an incremental decrease in the initial concentration of the target substance, which also decreases. For example, an exchange of around 1.4 times the estimated plasma volume, it decreases the pre-treatment levels of a substance approximately around 75% with minimal additional clearance beyond this 1.5 times the plasma volume. So in addition to this, the plasma concentration of the target substance, it decreases as a result of dilution by the replacement fluid, and hence these sessions typically exchange 1 to 1.5 times the volume. So the extracorporeal volume, which refers to the volume of blood outside the body during the exchange, should be less than 15% of the total blood volume to decrease the risk of complications related to hypovolemia. And if necessary, a blood prime or a transfusion may be required. So the estimated plasma volume that is calculated in this case is 0.065 into this 50 kg weight of this lady. In males, adult males, the number is 0.07, whereas in females it is 0.065 into the weight of the patient into 1 minus hematocrit in percentage. So that's 0.18. So that accounts to around 2.7 liters. So number of exchanges, how much is it to be done, for how long, and when it is to be discontinued?
Ma'am,
So,
Anish
huh?
ma'am, can I ask?
Yeah.
So in the previous slide, the way we mentioned the formula 0.065 into weight into 1 minus hematocrit. So this is the estimated plasma volume, right? 2.7 liters. And that's what we are trying to exchange. And so like the whole 2.7 liters would so you mentioned in the earlier slide that 60 to 70% of the volume comes out. So do we have to do the 60% of the total liters that we are getting with the formula 2.7 liters?
As in, you're telling in one plasma exchange, it is 2.7 liters or multiple sessions. Is that your question?
No, in one plasma exchange. In one session.
So Rohan, you exchange around 1 to 1.25 times the plasma volume in each session. That's what the calculation I told you the other day also. The total volume of that the patient which we have right now was coming at around 2.2 into 2.2 or 2.3 into 5, which was coming at around 8.9 liter exchange over 5 days. हम लोग ने कैलकुलेट किया था, याद है आपको?
Yes,
Yeah.
sir. Yes.
So that was based on 1.25% of volume being exchanged every day. So we are doing a plasma liter of around 2 liters approximately for her, 2.2 liters for her. She's a petite small lady with a hematocrit which was very, very low. So that's why we need to do a exchange transfusion daily. Sorry, actually plasma exchange daily, beg your pardon, which will replace at least one plasma volume every day. But what she's trying to tell you is that 60 to 70% of the plasma will remove around 70% of the toxins from whatever we are trying to remove in every cycle. But plasma volume should be at least 1 plasma volume per day. So it should be around 2 liters to 2.5 liters of plasma volume one day. For most of the times, we come to a round figure of around 2 liters, which accounts to around 60 to 70% of the total plasma volume. ऐसा होता है वो.
Okay. Okay.
Yeah.
So a 70 kg adult with a hematocrit of around 34% would require approximately 3 liters of replacement fluid for a single plasma volume exchange. So this will last approximately 1.5 to 2 hours with centrifugation technique, whereas with membrane filtration technique, it would be around 3 hours. I think Gandhi sir, you were asking for the duration of this each cycle. I think
to see our plasma exchange, what we do in ICU, it takes hour and a half only for the removal of 2 to 2.5 liters. Am I right or wrong? Most of the time it takes less than 2 hours,
Yes,
Correct or not?
Yes, sir.
So, and then you think it takes almost same amount of time it takes centrifugation as well as our membrane dialyzer. Okay, correct or not? Approximately same time, approximately, in my opinion.
So both the time, because so centrifugation has lower blood flow rates, whereas membrane filtration had high blood flow rates.
I know. Yeah, we keep 100 flow minimum. We keep it. Yeah, I agree with that point.
But sir, in centrifugation, we have a high plasma extraction, sir.
I
It's
agree.
around
I agree.
80%, and in membrane, it's around 30% only, sir.
Correct. That's very true. How about expense wise, Reshma? Have you got any idea? How much does it cost by the centrifugation? This, do you have any idea?
Cost wise, sir? No.
The
Cost-wise.
centrifugation becomes a little bit more expensive, but not too much, sir. I don't think the cost is too different.
I think cost is
It
very
must be
different. In my opinion, cost is different because there's that filtration, that disposable item cost significantly 25,000 rupees. That's what I was told before. I don't know now.
सर मैं पता लगाता हूँ मुझे भी
Pata
पक्का नहीं
lagao,
मालूम है सर
that's when
we
it
can
worth
find out
finding
sir
it out.
yeah
Sure.
Sir,
Okay.
it is a heavy equipment, sir. Because this is the same equipment which is used in blood bank also to
Yeah, yeah.
sir, to differentiate, to take out the different components of blood, sir, by
correct
centrifugation method.
correct
So
correct
same equipment they use it. Same equipment they use it. Okay.
It's a
It's
large
a
equipment.
costlier machine, sir. That is why the cost is a bit higher than the
And you cannot
membrane.
bring it to ICU. You have to send the patient to the blood bank. Correct or not?
नो नो सर वी कैन डू इट इन आईसीयू हमने एक बार किया भी है सर आईसीयू में फोर्टिस में तो हम उसी मशीन से करते थे इधर भी एक बार दो बार किया है बट सर कॉस्ट का मैं पता लगा के बताता हूँ आपको
मगर आप मेरे को बोलना कि ये the equipment is, I thought it's really big equipment. I don't know. I will find
it is
that
a
out.
big
Okay,
equipment
sure.
sir it is a big equipment agreed
Yeah,
it is a
correct,
big
correct,
equipment
correct.
yeah
Okay, sure.
बट सर फिल्टर का कॉस्ट नहीं मालूम मशीन एक्सपेंसिव अगर आपके पास मशीन ऑलरेडी बॉट है हॉस्पिटल में देन आई डोंट थिंक द कॉस्ट फॉर द फिल्टर फॉर सेंट्रीफ्यूगेशन वर्सेस मेम्ब्रेन फिल्टर is too expensive but I might be wrong completely you probably know better than me sir मैं
No,
कल
no.
पता लगा के आपको बताता हूँ सर क्या है कॉस्ट
बता मेरे को बता. It's worth finding it out. Okay, sure.
yeah sure sir
So the frequency and number of these plasma exchange sessions, this depends on what kind of substance you want to remove and the time required to reach the desired clinical improvement. So the determinants of the efficiency of this plasma exchange, it depends on the sieving coefficient of the membrane, plasma half-life, extravascular concentration, and rate of synthesis. So sieving coefficient means it's a measure of the equilibration of the solute across the semi-permeable membrane. If the coefficient is around 1, it indicates that there is a perfect equilibration across the membrane and it needs fewer plasma exchange sessions. Whereas if the sieving coefficient is around 0, which means that the solute doesn't cross through the semi-permeable membrane at all. Substances with shorter half-life, they may be synthesized more rapidly. So that would lead to a faster rebound and need for more plasma exchange sessions. Conversely, an exogenous substance with shorter half-life will have faster clearance. Extravascular concentration, where the substances have larger distribution, they will be removed more slowly because then they redistribute in the intravascular compartment. Rate of synthesis, if it's a faster rate of synthesis, it may require more plasma exchange or additional therapies to decrease the endogenous production. So this is a diagram that indicates that pre-treatment, how much the level is. Once they give the treatment, it will dip down to a particular level. But then again, because of equilibration between the intra and extravascular compartments, again, there is a slight increase in the level of the substance. Again, the patient undergoes the plasma session. So there's a dip down in the levels. Again, there is equilibration between both the compartments. So it shows a rise. So this is pre and post plasma exchange sessions. So this is about various immunoglobulins, albumin, fibrinogen. What is their plasma concentration? What is your mass, intravascular distribution, the turnover rate, and the half-life of the plasma proteins? So in this, we can see immunoglobulin G has a high plasma concentration rate, and it's whereas its intravascular distribution is around just 45%. Similar is with the albumin also, and its turnover rate is quite low, fractional turnover, and the half-life is more of the immunoglobulin G and albumin. Whereas with other substances, this is a tabular distribution of immunoglobulins, albumin, and complement. Sir, anything on this comparison that we need to know? I just wanted to ask on this slide. Gandhi, sir?
No, only one question, Reshma. I had on
Sir.
the previous slide of yours of redistribution and other thing.
Yes, sir.
Therefore, Hemraj's question, prolonged dialysis versus a twice a week day dialysis, far better in this rather than doing a prolonged plasma exchange. You get my point? Hemraj is saying that a prolonged dialysis,
Yes,
and somebody say
yeah,
twice a day
yes, sir,
dialysis,
yes,
twice
sir.
a day dialysis will much better than the prolonged dialysis. Correct or not? If
Only
required.
I wanted to ask this twice a day exchange that was told. What about the hemodynamic stability in this case compared to one exchange per day?
No, I don't think so. I think most of the, if you replace enough colloid and other thing, a patient tolerance it very well. 90% of patients have no problem in doing plasma exchange. Am I right or wrong? What is the experience in ICU? It's not very bad. Correct or not? So I would think that twice a day will be much better than the prolonged plasma exchange. What Emraj said about it. Emraj?
Yes, sir. Sir, some of the data also suggests that in acute cases, like in the patients with acute liver failure or with the patient of having high hemolysis and high LDH level and low platelet count, the twice daily plasma exchange, as Pandit sir said, in acute cases, different regimes have been suggested, and twice daily can be more beneficial in acute cases, sir.
I think so.
But it is a very short term. I mean, that data is not of any randomized control trial, unlike the other data, which has been used in number of trials now. And we have a formulated regime of either daily plasmapheresis or alternate day plasmapheresis. So this is more of an acute phase where the hemolysis is very bad. People have used twice a day plasmapheresis. Hemodynamic stability, as Gandhi sir is saying, is not a problem usually. Hemodynamic stability is very well tolerated. The problem arises when we start using blood products. Those can cause a little bit of
Reaction.
type of a picture or reaction, and the patient may become hypoxic. But otherwise, usually hemodynamics are not a problem. Correct, Gandhi sir? आपका क्या experience है?
I agree with that. I entirely agree with that point. I think
Yeah.
very, very few people had a problem with the plasma exchange, just to be honest with you, okay?
Yeah.
Sir, I would, sir, Vikrant here. Pandit
हाँ
sir.
विक्रांत बोल ना विक्रांत.
Sir, I would like to add one thing. I was just going through the literature while preparing the PPT. I always wondered why the plasma exchanges are done either alternate day, or generally people used to prefer it alternate day. So I went through some of the data that it states that most of the studies show that the immunoglobulins level or the antibodies which cause the autoimmune issues in most of the diseases for which the plasma exchanges are used, the antibodies replete in 48 hours generally, plus minus few hours. So that is commonly the reason why it is done alternate day. But as you said, depending upon the acuteness of the issue or the fulminance of the issue, it may be done daily also.
Yes, the extraction ratio is much better if you give at least 24 hours rest. But ideally 48 hours, because the antibody regeneration happens in 48 hours. So you need to give a 10-day cycle, but it all depends on if the patient has come to you with fulminant hemolysis. For first 24-48 hours, you might want to have a higher extraction just from what is circulating, and then give them a gap. That's why these different regimes have done. I think the best regimes are initial daily plasma exchange for a couple of days, and then go to alternate day regime. That is what I would personally feel is the best regime. But I really don't. It really doesn't matter, Vikrant. If somebody prefers alternate day regime, I am fine with that. I have no issues nowadays with that. Hmm.
So for the question that we asked, the daily exchange plasma of one plasma volume was the answer for it. And it is a first-line therapy for TTP, which reduces mortality from more than 90% to almost 5 to 10%. And TTP needs to be treated aggressively with 1 to 1.5 plasma volume exchanges. So, effect of a single plasma volume exchange on the removal and rebound of what we were discussing right now of these blood constituents using the albumin or crystalloid combination or single-handedly plasma as a replacement fluid basically. So this is a table that shows that how much is the baseline level of these constituents and after 48 hours post apheresis, how the levels rebound. So for TTP, FFP is the life-saving option as the plasma exchange removes the autoantibodies against the ADAMTS13 and the FFP provides the same, the functional ADAMTS13. So another case that the patient's weight, a male patient's weight around 100 kgs, hematocrit of around 34%. The plasma exchange or number of exchanges that was prescribed was around 1.5 times a EPV. So the same formula, as per the same formula, what is the volume that is to be exchanged, total exchange volume. So weight in kgs into 70 ml per kg for a male, adult male. That will be the total blood volume. And the estimated plasma volume will be the same total blood volume into 1 minus hematocrit. And the total exchange volume will be the plasma volume multiplied the number of exchanges. So in this case, as per the formula, if you see 100 kg into 70, that will be almost 7 liters. That is the total blood volume. Around the estimated plasma volume would be around 4.6 liters. And depending on the number of exchange or depending on the clinical case scenario, we decide on how much total volume has to be exchanged. That's all from my side, sir. Any questions?
Now we have had
Ma'am, I
loads
have.
of discussion.
Sorry.
Yes.
Sorry, sir. Sorry. Go ahead, please.
Now, Rohan, I think let us listen to Vikrant because we have already crossed 8 and then we'll take the questions. I think Vikrant will have certain answers already embedded in it. Please keep the question on, but let's listen to Vikrant. And we will have one more class on plasma exchange. Vikrant, please.
Sir, with due respect, I will divert difficult questions to you and Pandit sir and Gandhi sir.
Right.
So, good evening, everybody, esteemed faculty, Pandit sir, Arindam sir, Bhupendra sir, and my fellow colleagues. So, Dr. Reshma, I'm sure I am audible.
Yes.
Yeah. So, Dr. Reshma has given an elaborate presentation on the dosing and physiology. So, I'll continue with the rest of my brief part, which includes adverse reactions, contraindications, and some recent update. So, plasma exchanges is a very effective therapy, but it comes with its own baggage of issues and complications. So, if we consider this study by Lu et al., it shows the adverse. There is a lot of background noise. Can somebody mute?
Can everybody please switch off their microphones? Please mute the microphones. Thank you.
So it can be, the adverse reactions can be divided into primarily 3 parts. One is the replacement related complication. Another is the anticoagulant related complications. And the third one is the vascular access related complications. Okay, so the intention to share this table and slide is not to be adamant on the percentage of the incidence of the symptoms or the complications, but grossly to understand what are the types of complications. So if we consider replacement related complications, primarily it is allergic and the pruritus, urticaria, fever. These are the most common chills. These are the most common complications which are observed in most of the studies which are conducted till now world over. If we consider anticoagulation related complications, then numbness of the limb, which occurs because of the hypocalcemia and clotting of the circuit, these are the most common complications. And for the vascular access related complication, they are common as with any central line or SD catheter related complications like bleeding, hematoma, infection, thrombosis. So if to understand it more, it was initially postulated that the pediatric age group would be having more complications as the organs are delicate. But studies found it otherwise. The older age group appears to be more prone for higher complications, and it may be related to the higher dosage of the plasma. The more the plasma is used, the more is the susceptibility to the allergy. That seems to be the reason. Then patients with anti-NMDA receptor encephalitis had the highest incidence of complications in one of the studies. Carsten et al. Reported that the incidence of complication was highest in patients with neurological diseases. So another study showed some another most common disease with complications. So one of the study done by Shemin et al. It showed that the complications are higher with cryoglobulinemia and thrombotic thrombocytopenic purpura. Okay, but these are three most common diseases I found in the literature, which are found to have highest amount of complications. One is the neurological diseases, especially encephalitis, NMDA receptor encephalitis, autoimmune encephalitis. Another is the cryoglobulinemia and thrombotic thrombocytopenic purpura. Then Basic Juk et al. Reported complications in 509 adult patients with a big caseload, 4857 cases of plasma exchanges. And in them, there were hardly any major allergy related issues, but there were more of a hematoma and hypocalcemia related issues as they were using more of citrates. Now, after considering and understanding the adverse reactions, let us come to complications related to the types of fluid use. There is a big trilemma, as we have already discussed in brief in previous presentation, whether to use FFP or to use albumin or to use both. Now, the advantages of albumin is there is hardly any risk of hepatitis. Unlike in FFP, there is some risk of hepatitis. Albumin can be stored at room temperature. FFP cannot, it has to be properly preserved. Then allergic reactions are rare with albumin, but they are very, very common with the FFPs. There is no concern with the ABO blood grouping with albumin, but in FFP, it must be ABO compatible. On the contrary, albumin is expensive, but FFPs are not expensive. There are no coagulation factors in the albumin, no immunoglobulins. FFP has immunoglobulins and coagulation factors. So the chances of worsening of the coagulopathy is very less with FFP. Now the studies showed that FFP had significantly higher rates of adverse reactions than patients receiving other exchange fluid, such as 5% albumin. Again, still there is a lot of controversy regarding that. Many studies favoring albumin over FFP, but there are few studies and few centers still sticking to FFP based plasma exchanges. Allergic reactions to FFP are characterized by, as we discussed, fever, rigors, urticaria, wheezing, and in some cases severe anaphylaxis, laryngospasms. This is transfusion handbook of Joint United Kingdom Professional Advisory Committee. It states that plasma exchange with albumin or saline causes a transient fall in blood clotting factor and mild prolongation of prothrombin and activated thromboplastin time, which recover generally in 4 to 24 hours. But again, it depends on the prior status of the patient. If the patient is already coagulopathic, then this increase in the INR or APTT may be much higher. A narrative review in the intensive care medicine states that when albumin is used as a replacement solution, metabolic acidosis may be seen after plasma exchange session because albumin has an acidic profile. While on the contrary, if when plasma is used as a replacement solution, metabolic alkalosis may occur because of the metabolism of citrate used as an anticoagulant and citrate present in the stored plasma. A recent survey by ASFA, American Society of Apheresis subcommittee, found that wide practice variation in the type of replacement fluid, but the potential bleeding risk most often determines the choice. So whether to use FFP or to use plasma or to use both, again, will depend on the bleeding potential of the patient, coagulopathic situation of the patient. So it will vary on the choice of status of the patient, choice of the concert treating doctors, and institutional protocols. Now let us understand contraindications. Contraindications are few and specific. Non-availability of the central line access or large bore peripheral lines. They hold true for the membrane based plasma exchanges. Hemodynamic instability or septicemia. Again, this is a relative contraindication. Known allergy to fresh frozen plasma or replacement colloid or albumin. Known allergy to heparin. We have the alternative in the form of citrate. Hypocalcemia, that's again a relative contraindication because it can very well be treated. And angiotensin converting enzyme inhibitor used in last 24 hours. Again, it's a relative contraindication because you can treat because AC converting enzyme can cause severe hypotension, which in critical care setup you can treat. Now let us touch upon the advances as we were discussing in last lecture about centrifugation based plasma exchange and membrane based plasma exchanges. So world over, in Western world especially, up to 70% plasma exchanges nowadays are happening as centrifugation based exchanges. They are a bit on a costlier side, but they are quick as compared to membrane-based plasma exchanges. At the same time, the basic difference, as Arindam sir was asking in some time back, the basic difference is centrifugation-based plasma exchanges can help us get cytopheresis, which membrane-based plasma exchanges do not. Membrane-based plasma exchanges will give us plasmapheresis, but if we want cytopheresis, like for some specific indications like AML or essential erythrocytosis, where we want platelet pheresis, there the centrifugation-based technology will be useful. So one of the example is the Spectra Optia. There is no conflict of interest with this machine and the manufacturer. So one of the example is Spectra Optia apheresis system, which is widely used in Western world, USA and Europe. It separates plasma from other blood components in a highly effective manner. So it gives more patient comfort. It can be used and mind you, the most common or the majority of the plasma exchange happening in hematology units nowadays are centrifugation based plasma exchanges. They do not require central venous access. The anticoagulation required is citrate, so you can avoid issues and complications related to heparin. Okay, it's easy to access blood because it's easy to access peripheral veins, and you can do it on even on the OPD basis also. At the same time, it is more comforting to the patient. Moreover, Spectra Optia, this apheresis system, applies this technology to accurately calculate the required dose of exchange plasma. So this machine can give you the calculations also that how much plasma exchange you are supposed to do or you should do in patients. Now there is one terminology called plasma removal efficacy or PRE. It is a metric used to compare TPE devices. It describes the fraction of plasma that passes through the device and is removed per procedure. As Hemraj was mentioning, this PRE is extremely good with the centrifugation-based plasma exchanges. Up to 70 to 80% of the fraction can be removed. On the contrary, membrane-based plasma exchanges can remove 25 to 30%. Now, there is one more advent in the area of plasma exchange is that epoprostenol is used in some of the centers as an alternative to heparin and citrate, where both of them are either contraindicated or if citrate is not available. in the current scenario, citrate has been used world over, and up to 73% of the plasma exchanges happening world over, they use citrate as the anticoagulation. If we consider fluids, whether to use plasma or whether to use albumin, or other than these two fluids, if we can add some amount of crystalloid. So yes, crystalloid can be added for cost containment and in patients with hyperviscosity syndrome. And most of the institutes, they in fact use crystalloid. But again, however, the replacing plasma with crystalloid carries the risk of hypotension if we do not appropriately look at the patient hemodynamics, the osmolality which we are looking at, and the amount proportions. So generally, if the crystalloid exceeds 30%, I'm not considering here the albumin 5% part, because as Pandit sir said, world over 4 to 5% of the albumin used as a albumin and not 20% albumin. If the institute is using 20% albumin as one of the replacement fluids, then obviously this crystalloid percentage will exceed more than 30%. You will have to give more crystalloid. Now there are few studies and research going on about synthetic apheresis fluid also. So some of the renowned institutes in the world, they are trying to manufacture synthetic apheresis fluid, which will overcome the limitations of plasma and albumin both. So with plasma there is issue with allergy, and with albumin there is issue of lacking of the coagulation, or your coagulating factors going down, the level going down and increasing the coagulopathy. So what they are doing is they are combining IV fluids with fortified our coagulation factors, and they are trying to manufacture such fluids which will be compatible with human physiology. So that research is going on. Even though these studies, the study which I quoted in American Journal of Clinical Pathology, that was not very effective in giving a positive result, but yes, they are trying. Now, about drug clearance, as the therapeutic drug monitoring should be applied whenever possible in critically ill patients, as there are a lot of fluid shifts happening, lot of drugs or lot of proteins getting filtered. It's better if we monitor some of the very important drugs which have a narrow therapeutic index. So if we are using aminoglycoside, it's better if we preload the patient with dose of aminoglycoside for that day before starting the procedure, because their levels are going to drop during that procedure. And for beta lactams, they recommend giving a additional dose after the procedure to maintain the minimum inhibitory concentration. Again, rituximab is a highly protein bound drug, and its level is going to drop after the plasma exchange session. And this is the very reason, as Pandit sir was mentioning, that many centers are using plasma exchange for treatment of drug toxicities. So rituximab is one such drug for whose toxicity plasma exchange has been used world over. There are few other drugs also which many centers are using plasma exchange to treat the drug toxicities, namely eculizumab, mycophenolate, phenytoin, verapamil. But yes, rituximab is one such drug. It's used world over very commonly. Now there are some emerging indications in ICU. Severe COVID-19. I am not sure about how frequently it is used in the COVID era world over. I think Pandit sir will enlighten us about that, and how exactly it helps. I tried to understand it, but I did not understand what was the exact mechanism in how it helped in COVID-19. Maybe some benefit of antibody clearance. But yes, it was used quite extensively in few centers in severe COVID-19. Then systemic inflammatory. Yes, sir.
I will tell you, Vikrant.
Yes, sir.
There was one study which was considering using plasma as a plasma exchange, which had high titers of COVID-19 antibodies.
Okay.
So they were replacing the plasma with high titers of COVID-19 antibodies. So it was almost like a plasma therapy which we were using, or the monoclonal antibody, which is nothing but concentrated COVID-19 antibodies, monoclonal antibody which came out. So that is why plasma exchange was used. Second indication for plasma exchange was in like any other virus, COVID-19 also caused a lot of immune reactions like TTP and stuff for which they have used it. But the primary trial, which was initially been conceived, was to actually exchange the plasma using high titers of COVID-19 antibodies.
Okay.
Mm.
Okay. Thank you, sir. Then this makes sense because the systemic inflammatory response, it's a hyperinflammatory response. We are giving rise to hemophagocytic lymphohistiocytosis, macrophage activation syndrome, chimeric antigen receptor T cell associated cytokine release syndrome, severe pancreatitis, severe burns. These are the disease processes or syndromes we have witnessed that patients deteriorate very, very rapidly because of the extensive inflammatory load. And definitely it does not look like a rocket science where high plasma exchanges have been used world over and showing benefits in that. Then it has been used in few cases of vaccine induced thrombosis and thrombocytopenia, refractory cases especially in some of the centers in Europe. So these are some emerging ICU indications. Thank you very much for kind support.
Rohan, you can ask your question now.
Yes, sir. Thank you. Sir, I just want to ask one question that in any condition, if the hematocrit is low, which is generally in the cases of TTP, then is there any rationale that we should do less plasma exchange than the calculated volume by the formula? Is there a concept behind it? That's what I'm trying to ask. If the hematocrit is low, then if we do less plasma exchange.
Why did this question came up to your mind now, Rohan? What were you thinking better?
Sir, I will tell you. So, in a patient that we are seeing currently, the dose calculated according to the patient's weight, that was around, sir, 2.8 to 3 liters.
Correct.
And currently, we are doing the plasma exchange of only 2 liters.
That's 60 to 70% of the required volume. That's what I'm saying, trying to tell you.
So that was my first question. So when I asked the first question, that do we really do 60 to 70% only?
Yes.
Okay, sir. Okay.
So generally, that's what I'm trying to tell you, that most of the times you would land up giving 60 to 70%. अगर मैं सचमुच 1.25 times the plasma volume जाऊँ ना per plasma, I'll have to do a 3.5 liters of exchange. Now somebody with such brittle lungs and everything, we don't want to do that. That's why we spice it out. 3 to 4 plasma volumes over 5 days is what we try and exchange. ऐसा है वो.
Okay, sir. Okay. Now I understand, sir. Yes.
Yeah.
Arindam sir, I have a question for you. Hello.
Bolo, I'm listening.
Yes, sir. Sir, the patient for one of the patients which we are having right now with blast crisis, was there any role of cytopheresis in such a situation? Because he deteriorated very rapidly and then went on hemodynamic support. But when he was not on septic shock, whether the role of cytopheresis in such a situation with severe blast crisis?
Obviously, there is a role in the blast crisis, but by that time the patient came to us, he was in severe with a procalcitonin of close to 30 and with a blood pressure of 60. I think we didn't have time on that part. In fact, today we did the MDT and we were discussing the options that we could have done, or what we did, or we additionally could have done. So this leukocytopheresis option actually came up. In fact, in the next installment of plasmapheresis, not only hepatology and also some extended, I would invite an oncologist and an clinical immunologist, because loads of others, particularly in transplant, there is now extracorporeal other techniques where pre-organ donations, the plasmapheresis or apheresis techniques are being used. So we will discuss all those. But you are right, we could have done that, but by the time he came to us, unfortunately, we have missed that opportunity.
Yeah, and he was very sick at that time also.
Yes, yes.
Thank you, sir.
I don't remember. I used to have that paper, or it was almost like a book, which had more than 200 indications of plasmapheresis. I will try and search it out and I'll post it in the group if I can get it. Um, and each indication, there was a small note about that indication, why it is helpful. I'll try and search out that book.
There was a long list of indications along with like grade 1 evidence, grade 2A evidence.
Correct.
There was this.
तो है आपके
I
पास वो?
think this
This was sent. Put that thing on the mail if you can, please. Okay.
Yeah.
Yes, sir. Yes, sir.
Okay. Thank you. Thank you.
Thank you, sir. Okay,
Thank
guys.
you.
Thank you very much.
Thank you,
Bye-bye.
sir.
Thank you. Thank you, sir.
thank you,
Bye.
sir.
Thank you, sir.